Okay, so whose turn is it? Who has the, okay, so Eli, we've done number 6, so number 7.
Number 7 is regular rates 70. There are P waves present. The PRI is normal, QRS is normal, but there's one escape beat.
Now, what are you calling, how do you define an escape beat?
It is an atrial complex, but it comes late in
So which one are you calling that?
the wait a second.
Do you have the pointer? There it is. Show us.
Well, I was calling it that one,
Okay.
but that's normal with this. That's regular. Maybe it's just a normal sinus rhythm with a sinus pause.
Okay, you're possibly, but then you have to tell me what that thing is.
I know that. I have no idea. It's a. Yeah.
So first of all,
T-wave.
so let's march it out with the other. How does it relate to the P waves? Is it in line with the P waves? Early, late? What do we think here?
It's not in line with the P waves.
Is it early, late?
It's early.
Okay, so we've got an early something or another, okay? So it's premature. So Brandon?
Is it a non-conductive PAC?
Yeah. So remember, so this in and of itself, what happens is there's an ectopic focus here that fires off that's within the atrium, okay? And that's what this P wave is. It's an atrial P wave. Its upright comes in early. However, probably because it's so early, the impulse goes down to the AV node, and either the AV node is still refractory and not able to transmit the impulse, or else it does that and the ventricles are refractory. So in other words, one way of thinking about it is this ectopic focus fires off during the absolute refractory period. And so the ventricles are just not ready to go. So we get the P wave, but we don't get the following QRS. So when we say non-conducted, what we mean is non-conducted through the AV node. So the answer here is a normal sinus rhythm with one non-conducted PAC. Okay? And here's the, oh, well, let's just go to the next one, and then I'll come back and talk about that one a bit.
All right. So this looks like has a regular. Oh, I'm on 8.
Yeah.
Yeah, it looks regular. The rate is about, I would say 50
Okay.
beats per minute. So bradycardic, and P waves are present. PR intervals look normal. Same with QRS complexes. T waves are inverted. And yeah, so sinus bradycardia with, is that a sinus pause?
Yeah, or sinus block, it is. Okay, how do we know? It sure looks similar in a way to the sinus rhythm with a non-conducted PAC. How do we know? Are you sure this is not like a non-conducted PAC that's causing that pause? How do you know?
I'm sure.
Okay, somebody help them out. Why is this a sinus block or sinus pause and not a non-conducted PAC?
P wave.
Yeah, there's no P wave. So if you look, now you've added something to what you have to do when you see one of these pauses. You have to look. This one is pretty obvious, but sometimes they're pretty small. And so when you see something that you think is a sinus block, really look. Is there some kind of little blip? Does it look exactly like this one? Yeah, it does. Okay?
So if there's a P wave before the sinus pause, it's a PAC.
Well, then it's not a sinus pause.
Okay.
Because think about it. Remember how insistent I am that you say sinus block or sinus pause? The reason is because that tells us that the problem that causes the pause is within the sinus node. Either the pacemaker's not working, or it's got an exit block and it's not allowing the impulse to get out of the SA node. But when you have a non-conducted PAC, this is causing the pause, okay? Because probably what happens is that the SA node is scheduled to fire off right about here. And probably it fires off, but because of the non-conductive PAC, the atria are refractory and not depolarizing. So that's what causes the pause. The non-conductive PAC, or a PAC, causes the pause. That's why there's a bit of a pause after all these premature beats. Okay. Okay. And last one, number 9.
So it's a regular rhythm. So regular. It's about, what did I say? Like 75. There's no P waves present. So there's no PRI. The QRS does look normal though, so atrial flutter.
Yeah, atrial flutter, is that what you said? Yeah, again, and again, the trick is to recognize the flutter waves. Okay. If you're having trouble recognizing flutter waves, the best way is just to look at a lot of atrial flutter. So my suggestion is take the workout book and go to the end where the answers are and jot down like 7 or 8 different atrial flutters, like the page numbers. Go look at them one right after another, and you'll start recognizing them. Yeah, Faf.
This is, so how do we define the difference between atrial flutter and a P wave? Like, what is the physiological difference?
So, one of the things that you might have missed from last week are what these reentry pathways are. So be sure this week to go back, and because that's pretty important. But essentially what happens in atrial flutters is what's called a reentry pathway, which is a very rapid circular pathway of impulse transmission.
But does the atria contract at all, or is the
No,
impulse
no,
just
it's,
running around?
no, it can't possibly, because it's being depolarized 300 times a minute. So it's just this impulse that when these reentry pathways establish themselves, they're very regular and they're very rapid. And so it's just going, this electrical impulse is just going round and 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 round the atria, okay? And it's every time it goes around, it depolarizes the atria. So there's no possible way for the atria to contract.
So in a way, in like the very basic definition of a P wave, it is a P wave but more specified because it is an atrial depolarization, but it's specifically a flutter.
Well, yeah, so I understand the question, and I'm going to give you a little bit of a sloppy answer because I think the definition in and of itself is a little bit sloppy. I'm reserving P waves, and again, it tends to vary a little, so it's a very good question, but like I said, it's kind of a sloppy answer. I reserve the term P wave for sinus P waves and atrial P waves like PACs, because it's a very distinct, singular entity that leads to the QRS, okay? Today we're going to be talking about inverted P waves. I'll still call them inverted. Now, are flutter waves P waves? Actually, some people do call them P waves, but more commonly they're called flutter waves, or sometimes you'll see small F waves, okay? And I think F waves is just too confusing. I just call them flutter waves. And mostly I'm distinguishing them from the other depolarizations of the atrium. You're absolutely right, though, in the sense of, way back when I said, what is the P wave represent? It represents atrial depolarization. Then it's a very logical question to say, well, aren't those P waves? And yeah, you could call them that, but I tend to call them flutter waves just to make clear what they are. So it's more of a nomenclature thing than anything. Okay, so hopefully today, see what time? Oh yeah, we're gonna have plenty of time. We will get out by 3:30 latest, maybe a little bit before. I want to get to the end of the discussion of SVT. So I want to go through junctional rhythms, and we'll take a break somewhere around here in the middle of junctional rhythms. Who remembers this is the one type of rhythm where it originates is not totally obvious from the name? Where do junctional rhythms originate? AV node, absolutely. The junctional rhythms that we're going to talk about today is premature junctional. This should be complex. Contraction is old school. So PJCs, not really a rhythm, just a single beat. And then the main junctional rhythm we're going to talk about has the name of junctional rhythm. Okay. The other names for it are junctional escape rhythm. Sometimes you'll see an ectopic junctional rhythm. I don't have it up here. Old school is idiojunctional rhythm. And then we're also going to talk about accelerated junctional and junctional tach. So junctional rhythms are much easier than atrial rhythms because there just aren't that many of them. Now, Brandon, junctional rhythms are supraventricular, therefore they have what? Narrow or wide QRSs? Okay, unless CAFE, unless what? What would be the exception?
Unless there is an IVC.
Correct. Okay, so again, we're going to expect all of these junctional rhythms to be narrow unless there's some kind of interventricular conduction delay. Now, when we talk about junctional P waves, there are either no P wave at all, or inverted P wave, or something that we call retrograde P wave. So why is that? So let's look at a picture here. So, when the impulse, so by definition, if it's a junctional rhythm or a junctional beat, the impulse originates in the AV node. Okay, the ectopic focus is here. The pacemaker here fires off, and it will go straight down through the bottom of the AV node, jump on the bundle of His, and get on the speedy conduction system and depolarize the ventricles. Sometimes that's all that happens. There's no electrical impulse that goes back up into the atria. So if that's all that happens, is there going to be no P wave or an inverted P wave? Nicole, what do you think?
No.
Correct, okay, because there's no atrial depolarization at all, okay? But sometimes what happens is that the impulse goes down into the ventricles, but it also goes back up into the atrium. So Cammie, if that happens, what are you going to see? No P wave or inverted P wave?
Sorry, say that all again.
Okay.
I'm trying to catch up on the notes.
No, that's good. Ectopic focus here
Yes.
depolarizes downward into the ventricles, just like the previous slide, but sometimes it also will go backwards up into the atria and depolarize the atria backwards. So what are you going to see then? So lead 2 is down here looking up,
Yes.
and the QRS is just going to be a plain old QRS, there's that. But what's it going to see with this backwards depolarization?
Inverted.
Yeah, it's going to be inverted. So let's look at some examples here. So here's an example of a junctional rhythm with no P wave whatsoever. Just a QR, it's just ventricular depolarization, ventricular repolarization. That's all that's happening over and over again, okay? Here's where we have the backwards depolarization, so from the AV node back up into the atria, so we have an inverted P. And then sometimes we have what's called retrograde P waves. And first of all, there's no clinical significance of which one it is. Okay, none of these have atrial kick, none of them have atrial contraction and atrial kick. So it doesn't matter, it's just ECG talk. No P wave, inverted P wave. Retrograde P wave are these little blippy things behind the QRS. And what's happening there, let's go back and look at our picture. Okay, this picture. Okay, so what's happening there, when you see the inverted P wave that precedes the QRS, that means that this depolarization occurs before that depolarization. So we see the inverted P because the backwards atrial depolarization occurs prior to the ventricular depolarization. But if this one happens afterwards, this one goes first, this one goes second, then we're barely going to see this one at all because it's going to be kind of buried in the ventricular depolarization. But sometimes what we'll see then is exactly what we see here, is ventricular depolarization happened first, and then atrial depolarization occurred, but we can't really see it very well because it's kind of buried. It's that little blip there is the retrograde P. Does that make sense?
So these are all three signs of how P waves look in junctional.
Correct. And again, just to be clear, it doesn't matter in terms of the patient whether they're in a junctional rhythm with no P wave, an inverted P wave, or retrograde P wave, makes no difference as far as cardiac output. But, you know, like we have to explain what's happening on the ECG.
This is
Yeah.
for all of the junctional rhythms?
Yes.
Okay.
Okay, we'll do the PJC and then we'll probably take a break. So a PJC is very similar to a PAC. The only difference is where the ectopic focus is, where the irritable ectopic focus is. And in this case, in the atrial, PAC, it's in the atrium. PJC, the irritable ectopic focus is in the AV node, okay? And because it's junctional, because it's out of the AV node, that single beat, that single premature beat will either have no P waves, inverted P waves, or even a retrograde P wave. And we'll look at some pictures in a moment. So, premature junctional complex, we're talking about the criteria. First of all, talking about the rhythm, the regularity of a single premature beat makes no sense, right? So the underlying rhythm is usually regular, made irregular by that single beat, okay? Rate, there's only one, so we can't talk about the rate. P waves, it's junctional, maybe absent, inverted, or retrograde. PRI, if there is a P wave, not always, but usually it's short. QRS, it's still supraventricular, so it's usually narrow. Now, if there is an IVCD in the normal sinus or the sinus rhythm has a wide QRS, the PJC will as well. Okay. I'll just let you look at this slide. Okay, so let's look at some examples. So in this case, this one is not terribly premature, but it does come in a little bit premature. And you can see it's a premature beat. It comes in early. How do we know it's a PJC? Well, it's got an inverted P wave. Okay. Okay. How do we tell a PAC from a PJC? Sometimes it's not possible, but if we can, we should. Now, clinically, it makes no difference at all whether it's a PAC or a PJC. It makes no difference. But if we can tell on the ECG, we should try to do so. So a PAC, the P wave that precedes the QRS, it's usually upright, or else you can assume it's upright because it's buried in the preceding T, which has become larger. A PJC the P wave is buried following the QRS, or there is no P wave. So let's just do some. That's easy. The examples make it much easier. So Abigail, your two premature beats are here and here. Are they PACs or PJCs, and how do you know?
It looks like PAC because the P waves are upright and they precede the QRS complex.
Yep. Okay. So PACs. So that would be a sinus rhythm with two PACs. Okay. Everybody following this? Okay. Haley, what about this one? Here's your premature beat.
There is no P wave before the premature beat. So PJC.
Should we vote? How many people think it's a PAC?
Oh, it's buried by the P
There
wave.
you go.
Never
There
mind,
you go.
PAC.
Good. 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 Good.
Got it.
Okay. So remember, now, are we 100% sure? No, we're not 100% sure, but we're pretty sure. Because this T wave is so much bigger than these, it's that situation, you know, where I drew where the P wave, the P wave and the T wave are piggybacked together, and so it's that much larger. So in this case, we're pretty sure it's a PAC. Okay. Okay, what about this one? Here's your, where is it? Here it is. Here's your premature beat. Which one do you think that one is?
I'm gonna say PJC because the T wave was after the preceding one.
Correct. So there's no obvious P wave. And it doesn't, you know, the T wave, exactly like you say, looks exactly like the other P waves. And so we're assuming there is no P wave buried in that T. And then, let's see, Brandon, how about this? You've got two, one is here, one is here.
I'm gonna say PAC and PJC.
Yeah, good. So PAC, because there is a P wave, and PJC, because there is no P wave. Now this is pretty unusual. Usually if there's an irritable ectopic focus, that's what's throwing it out. But in this case, we seem to have one in the atria, one in the AV node.
So if we're describing this,
Yeah.
just
You would
saying
say a
one
normal
PC.
sinus rhythm with one PAC and one PJC. Okay. And again, just to be clear, I'm not sure, but I don't think you're going to be spending a lot of your internship talking about is it PAC or PJC. It's simply not, clinically, it's insignificant. In fact, to be honest, the PAC and the PJC typically, unless there's a whole bunch of them, is not clinically significant either. Okay. But still, you need to know it.
That's why I look at the app.
Okay.
Yoo-hoo.
We're back.
You've fallen in?
Okay.
Yes. I mentioned it the other day and everybody was like, what do you mean you fell in? I was like,
Junctional rhythm.
Okay. On to other less important topics. So our next junctional rhythm is junctional rhythm, okay? And this is the one when you think about what happens when the SA node dies or slows way down, the AV node comes to the heart's rescue, and this is it. It's called junctional rhythm. Sometimes it's called junctional escape rhythm, ectopic junctional rhythm, and again, old-fashioned idiojunctional rhythm. It originates in the AV node, takes over when there's a problem, a long problem with the SA node. It is regular. It is always regular, okay? The rate, by definition, probably more accurate would be to say less than 60, even though most references say 40 to 60, because it does go slower, and there's no formal junctional bradycardia. It's just always junctional rhythm. So you can put 40 to 60 if I ask you, but really I think a better representation is less than 60. P waves, because it's junctional, are absent, inverted, or retrograde The PRI, if there are P waves, not always, but typically it's narrow, it's not wide. And supraventricular, so the QRS is narrow. Etiology, I'll let you read it. Don't worry about the AV block, that won't make any sense to you for a few weeks. There's some AV blocks that have junctional rhythms in them. And again, that won't make sense, just kind of learn it and it'll make sense in a few weeks. This is what a junctional rhythm, this particular junctional rhythm has no P waves at all. It's narrow, the QRS is narrow. The rate is 10, 20, 30, 40, so about 45. It's less than 60, so this is a junctional rhythm. Now, the other two junctional rhythms we're going to talk about are accelerated junctional and junctional tach. And they're really simple. They're just faster versions of junctional escape. So, for example, we learned that the intrinsic rate of the AV node was 40 to 60, but a junctional rhythm, if somebody is in a junctional rhythm, and the tiger comes into the room, your heart rate is still going to go up. You're still in the junctional rhythm, and your heart rate goes up, and that would be an accelerated junctional rhythm. So by definition, the only difference between junctional rhythm and accelerated is that junctional rhythm is less than 60. Accelerated junctional is between 60 and 100. And then if it goes faster than 100, it's junctional tach. The only difference between these three rhythms is the rate. Everything else is exactly the same. So this is what I call the junctional rhythm continuum. If it's junctional, you need to learn this. If it's less than 60, it's called junctional rhythm or junctional escape. If it's 60 to 100, we call it accelerated junctional. If it's greater than 100, we call it junctional tach. Unless it's so fast that we call it SVT, but we'll get to that as the lecture goes.
Is there any such thing as junctional bradycardia?
No, there's not. So that's why, not formally. I mean, you could call it that, but it doesn't make sense because it's all less than 60. So that's why I use less than 60. A lot of references will use 40 to 60, but junctional rhythm can go slower than 40, so I just say less than 60. Okay, so here's the our formal criteria is the only difference between this slide and the junctional rhythm slide is the fact that I added accelerated and I changed the rate to 60 to 100. Other than that, it's exactly the same. I'll let you read that. And then this is what it looks like. Again, no P waves, quite regular, narrow complex. And in this case, I think the rate here is about 80. So it's faster than 60, but slower than 100. It's an accelerated junctional rhythm. The only difference between this slide and the preceding ones is I changed the name to junctional tach, and then I changed the rate to 100 or greater. And different references have a different, like how fast it can go. Some will say it's between 100 and 130. Others will say 100 and 150. Others will say 100 and 180. It gets complicated because once it gets fast enough, it starts looking like the other SVT rhythms. And that should make sense to you in about half hour. Okay? So here's junctional tach. The rate's about 120. It's regular. You can see there's inverted P's. Now, when the rate of junctional tach gets so fast that even if there are P's, they disappear, then we're going to start calling it SVT because we no longer will be able to, when it gets fast enough, we no longer will be able to distinguish between junctional tach and atrial tach and then these two rhythms which we're about to talk about. So there are 4 rhythms under our umbrella term of SVT, and junctional tach, when it's fast enough, is one of them. So for example, this rhythm here could be junctional tach, but it could also be atrial tach, as far as we know. Now notice the way we describe these rhythms is they're regular, the QRS is narrow, they're very rapid, and there's no discernible P waves. Okay, so let's, yeah.
So I had a question. So you can either have the retrograde, the inverted, or the absent. Would you have, would there be an instance like with WAP where you'd have like all 3 in like a 6-second strip, or would it always just be like either inverted or just absent?
It would always be the same. Yeah. Okay, so this one is on page, I think this is page 21 in our handout. Yeah, it says atrial junctional, no SVT. So who's got the pointer? Okay, you're number 1.
So these are junctional rhythms?
Well, you tell me.
Okay.
Well, but so here's the deal. Most of them are, not all of them. There are some atrial, there's some sinus.
Okay.
Okay.
So this looks to be at a regular rate. P waves are not present before each QRS complex. I would say the rate is about 80.
Okay.
QRS complexes within normal length and T waves are present. So
Okay.
is this a junctional rhythm?
Well, it's one of the junctional rhythms.
Accelerated.
Perfect.
junctional.
And do you remember what's the limit of accelerated junctional?
It is 60 to 100.
Uh-huh. Yeah. Now, everything you said was perfect. I'm going to comment that it's fine that you mentioned the T waves, just as long as you recognize that in the process that we're doing now of identifying what it is, the T wave is irrelevant.
Yes.
Okay. By all means, go ahead and say it. So, okay.
Number 2, the rate looks regular, and it's about 50 beats.
Okay.
There's no P wave, so there's no PR. QRS looks good, so a junctional rhythm.
Yeah, and just plain junctional?
Just a plain junctional
Yeah,
rhythm.
exactly. Okay, because it's less than 60. And, everything you said was perfect. I'm going to quibble a little just because we're in the ECG class. There actually are some P waves, they're those retrograde ones.
Said that, yeah, the
Yeah.
retrograde.
Yeah, and
Okay.
again, it's not, it doesn't change anything that you said. It has no significance other than we're in ECG class.
Exactly.
Yeah.
Gotcha.
Okay. Okay, Abigail, you are next.
The rhythm is regular besides, regularly or, wait. Underlying rhythm is regular except for this right here.
Yes? Yes. Okay, good.
Rate is 70-ish?
Well, 10, 20, 30, 40, 50. I think it's probably closer to 60 myself.
Oh, I can't count. That's
Oh, okay then. That excuses it.
And there are P waves present, but they go back. Oh, sorry, I can use this. The P waves are present, but they go inverted. I think it's just inverted at this one weird.
Okay.
Can you point out the feet?
I'm sorry, my hands don't stay
Here,
still.
here you go.
Okay, I see it.
Get out of here.
I see it.
So what is it?
Well, what's the underlying rhythm? Like, ignore this section here, because this is the oddball, and let's just look at the second half. Okay, that shouldn't be hard. What's that? That, yeah, I know you can do, because you passed your quiz.
I mean, then if you know I can do it, then it must be sinus.
Yeah, it is sinus. It's got upright P's.
Yeah, and then we said that it was about 60, so it.
Yeah, so
sinus
borderline
normal,
sinus
possible
Brady. And then we have one oddball beat. So when you took your calipers to see if it was regular, how does this one line up with the others? Is it early? Is it late? How does it relate to the others?
It was early.
Yeah, it's not early by much, but it is early. Okay, so typically when there is a single early beat,
It's just the premature.
it's a premature beat. So the question is, it was easier about a half hour ago because we only had one premature beat, but now we have two. We have PACs and we have PJCs.
Oh, right. PAC. Oh, no, wait. PJC because it's inverted.
Perfect, perfect, there you go. So it's a borderline sinus Brady or normal sinus rhythm with one PJC. Good job.
Okay.
Okay, next.
So those one PAC?
PJC, because the P wave is inverted, that means it's junctional.
If it was a PAC,
I don't know what
then
it is.
the P wave would be upright.
Correct.
Alright. There is an odd to.
Okay?
So other than that, it is regular. I'd say the rate is about 75. And I would say that there are P waves present.
Okay?
PRIs are normal. QRS is good. I'd say that is a premature atrial beat.
Okay, so put the whole thing together though.
So normal sinus rhythm with one premature atrial
Yeah,
complex.
yeah. Or you can just say, that's fine. You can also say PAC and that's totally fine.
Okay.
Okay, yeah. So now let me point something out to you. Look at that isoelectric line, how squiggly it is, okay? And, you know, those of you who have seen field ECGs know that's nothing like the interference that you'll see when a patient is moving is much more dramatic than that. But I'm pointing this out because this looks a whole lot like fib waves, okay? But it is regular and it has P waves, so it can't be a fib. Now I say a lot, don't depend on the fib waves to identify atrial fibrillation for two reasons. Number one, a lot of AFib doesn't have fib waves. And then you get stuff like this, where it's a normal sinus rhythm with what looks like fib waves, but it's just interference. Okay, so artifact. Okay, next one please, number 5, whoever's next.
Yes, alright. Alright, it's all regular. Our R to R is all regular. Heart rate. Oh, 100.
Okay,
Looks like we have inverted P waves. I think, yeah. PRI, good. And QRS is good too, so. So accelerated junctional rhythm.
yeah, and it's right on the border with accelerated and what?
Oh, and junctional tachycardia.
Yeah, so you're fine with it's again, it's one of those borderline rates. So accelerated's fine, junctional tach is fine, borderline junctional tach is also fine. Okay? Okay. Whoever is next. Let's see. What number are we on?
Around 6.
Okay.
Okay, so the rate is regular, or the rhythm is regular. The heart rate about 110 to 120. I think the P waves are inverted.
Uh-huh.
it looks like to me. So I think this is gonna be junctional tack.
Perfect. Okay, questions? Okay, next one, number 7, please.
One second.
What was number 5?
Junctional tack. So it's regular, it's got inverted P's, and the rate's above 100.
This
Oh,
is
number 5?
Yeah.
Well, I don't know, what was number 5?
Oh, accelerated.
Yeah, accelerated junctional, sorry.
Or one of the ones.
This one, it's like I need a few more vitamins for this because it's not super easy on the first one. It's kind of like the last one I did, where there seems to be, it's an irregularly regular rhythm, but again, that first one is a lot larger than any of the other ones that are repeated. I'm gonna go with the regularly irregular.
Okay, so let me jump in there. When you say, you're saying regularly irregular? So what's the pattern that you're seeing?
I'm seeing.
Because certainly there's a lot of difference across, so you must be seeing a pattern because,
So I see a clump here,
okay,
a big gap, a 3-beat clump, and then this gap is also bigger, and then there's 3 beats, and then
Uh-huh.
this gap.
so but with these 3 beats, so what are you calling, like, is this the R to R that is sort of the underlying R to R, if you will?
Mm,
So this one, okay, so this one, yeah, it's pretty close, but that one is not close. That one, pretty close, but that one, not close. Now that one is a little bit short. So I'm gonna call this irregularly irregular, partly because I know it, but partly because one of the problems with the 6-second beats, and this is not a terribly fast rhythm, is you don't have a ton to go on. And again, we love to see patterns. Like we're always trying to find patterns in things that aren't there. And finally, this is irregularly irregular. That doesn't mean that everything has to be different. It's just random, meaning that sometimes there can be some similarities.
So don't stretch to find the pattern.
Yes, that's good. I'll steal that. That's a good line.
Rate of about like 85.
10, 20, 30, 40, 50, 60, 70. Yeah, I'll go with that.
P waves. There seems to be a lot of artifacts. I'm not seeing any defined P waves, so I'm going to say absent.
Good.
Okay. That means there's no PRIs, and the QRSs are about 1 box, which is within range.
Okay.
So,
So let me help you out here. It's irregular. Once you get to the point of irregularly, first of all, when you hear irregularly irregular, what should kind of flash into your head is, oh, AFib. Doesn't mean it is AFib, but it suggests it probably is AFib. So then you look for the P waves, and if there are no P waves, then you're home free. Then it's AFib.
okay.
So even if you end up with a wide QRS, all that means is it's AFib with an IVCD. Okay, so like a bundle branch block or something. Yeah, so this is AFib. And, you know, I said don't hang your hat on fib waves, and you shouldn't. But on the other hand, now that we know this is AFib, we look at it and say, oh yeah, and there are fib waves. So,
How do we know via PowerPoint, like if those are retrograde P waves or not?
which one?
For 7,
Which thing do you think is a retrograde P wave?
right after the QRS?
This, like, here?
Yeah.
And there, and there. So what's happening is here. So first of all, let's back up a minute. If they're retrograde P waves, what does that mean, you think, based on what you know now? Where do you think the rhythm originates?
It would be junctional.
Okay. Why is it impossible for this rhythm to be a junctional rhythm?
Oh, junctional is regular.
Bingo.
Okay.
Yeah, it's like you have to put it all together. You know,
Yes.
you have to sort of shuffle through all the facts and say, well, what makes most sense? Well, it can't be junctional for that reason. Okay. Good question. Okay, who's next? Brandon, I think it's you.
The rhythm looks normal. The rate is about 70, I think. I'm having trouble with the P waves, so the QRS looks normal, so I'm thinking it's either a flutter or an accelerated junctional rhythm with a retrograde P.
So, here's first of all, it is atrial flutter. You know, I think I've already said this, but I'm gonna say it again. I'll say it again at some point. The only way to learn atrial flutter is to recognize flutter waves. There's no other way to do it. And what makes this probably a little more difficult is that there's ST depression, which pulls this one down, and then it looks as though this particular flutter wave is landing on the T wave every time. And so that's why this one is bigger, so you're seeing T waves. But it has the definite flutter wave pattern. So. Questions?
Are there retrograde P waves in that?
No.
So those little notches, like in the third QR after the third QRS.
Third QRS, 1, 2. This?
Yeah. No.
This?
Yeah.
Okay. Does anybody know what that is?
Is that the biphasic
Yes, you got the right idea. You didn't say it all that great, but you got the right idea. So, it's the S wave. Remember SS prime. Remember R prime.
Yes.
Oh,
Right. So it's kind of SS
Oh,
prime.
okay.
R. Oh, I get what you were getting at.
Yeah. No, she was right. She was right. Yeah. Yeah.
Did you say there's ST depression there?
Oh my
Yes.
God.
Because I would put the J point right about here. So, right here. So actually, the QRS is a little wide, but not terribly wide. So, yeah.
What
Okay.
would the retrograde P waves look like with the T wave as well?
Well,
Would it be hidden, or would it be poking out a little bit?
in order for usually if there's a retrograde P, it's right directly after the QRS, and so it rarely gets tangled up in the T wave. It's possible, but I mean, I can't tell you. And the other thing is, if it's there, you probably wouldn't see it because the T wave would just get sort of buried in the T, and you wouldn't see it. So, yeah.
Would it be fast enough to be within the ST segment right before that T?
It could be. Yeah, absolutely could be. Yeah. Okay, who's next?
Me.
Okay.
It is.
Oh, sorry.
That's what I'm saying. Yeah, it's
Sorry.
regularly irregular, with a rate of 80. There are P waves present. PRI and the QRSs are normal. I think it is a normal sinus rhythm with 2 non-conducted PACs.
Brilliant.
Whoa,
whoa. Okay, you need to point out the non-conductive PACs.
Right. A P wave right here.
It's like running the marathon. Okay,
Right.
go ahead.
There,
Yeah.
there, and then there, and
Yep,
then there.
yep. So let's go through this. So first of all, I think everybody can see, what was the rate on that, 300, yeah, it's about 90. So everybody can see here, I think, that the underlying rhythm is just a normal sinus rhythm, correct? Okay, everybody happy with that? Okay, so now let's kind of, and then at first glance, it looks as though it's just a normal sinus rhythm with 2 sinus pauses or sinus blocks. However, remember, it's your job now, because you know about it, to look for non-conductive PACs. And if you look at what's happening here and then compare it, see how the T wave, see how what's normally happening is, let me draw this one. On beats 1, 2, and 3, this is pretty much what it looks like. There's a P wave, like that, and then the QRS is just an R wave, and then the ST segment kind of does this, and then there's a inverted T. Does everybody see that? Okay. But if you look at the 4th beat, also the 5th, 6th, 7th, the 8th beat, it doesn't look like that, because there's like a little bump right here, just like that. Okay? And that makes it look different. See that little bump? It's not the same as these. Okay? So you have to say, well, what exactly is that? So what's happening here is that we have our normal sinus rhythm, and then there's an ectopic focus in the atria that is really premature, okay? It even happens, at the very beginning of ventricular repolarization. So it's no surprise that it's not able to conduct, because certainly the ventricles, we're in absolute refractory period, we're like right in the middle of it. And so that's what that is. And then it goes back to normal, and then there's another one, okay? Does that make sense to everybody? Great job.
So what was this rhythm?
It's a normal sinus rhythm with 2 non-conductive PACs. Okay, next one, please.
All right. So the rate here looks to be, I would say, irregularly irregular.
Good.
It's about 2, 3, 4, 5, 6, 7, about 70 beats per minute. I can't tell if P waves are present or not.
They are not.
They are not. This kind of looks like, is it atrial fibrillation?
Yes, it is. Say fib.
And
You can stop right there.
yeah, okay.
Yeah.
That's all I got for that.
I mean, if you, feel like talking, but I mean, Okay, who's next? Number 11.
So the rhythm is regular. It's about 65, 70, or wait, 75, so like 70.
Okay.
The P waves are inverted, if I'm seeing them right. And they're all the same. PRI looks normal, the QRS.
Okay, let's go back. It's not going to change anything for you, but it's absolutely not a
It's
normal PRI, no matter how you look at it. I think
This
there's a
one looks small.
Yeah, it's
one of
really-
them looks different, but
yeah.
most of
Okay.
them are smaller, so it's small.
Okay. Yep.
The QRS is normal. So. I'm kind of stuck. I'm separating.
Okay,
all these.
so it's regular.
Yeah, so it's a junctional. Yeah.
Brilliant. And which one?
It's 75, so accelerated.
Yeah.
Okay.
There you go, good job. Okay, next, please.
That you.
It's regular, and it looks like 120-ish.
Uh-huh.
I can count this time. There are P waves present. Oh, yeah. And they're all upright. And so that would make it.
It's tricky because it's too easy.
Is it just sinus
It is.
tack?
Just
Okay.
sinus tack. No, I gotta keep you honest,
Throwing
so,
around the
yeah.
sinus rhythm.
Okay.
Wow.
Normal sinus rhythm, yeah.
Oh,
Or
sinus
sinus
tack.
tack.
RR is regular, rate is about 150. I do not think that P waves are present,
Okay,
so no PRIs and QRS is good. I would say that's atrial flutter.
it's atrial flutter. And again, it's just a matter of recognizing the flutter waves.
Thank you. Alright, okay, oh no. You that is like, oh, wait a second, maybe you don't. R2R looks regular. Heart rate. 75.
Okay.
No P waves. So no PRI. And QRS looks good. So 75, so accelerated junction.
Okay, so let me ask you something.
Oh dear, yeah. Oh, is this?
Let me just ask you.
Yeah, go for it.
I look at it and I think, wow, no P waves, narrow QRS. Are you sure this isn't atrial fibrillation?
That's a solid question.
Thank you.
Let's see, with AFib. Oh, it's regular, so.
Good, there you go.
So no
There you go.
regular.
Yeah, okay. I was
Got
like,
you.
wait, anyways.
Yeah.
So it is accelerated.
It is accelerated. I'm just messing with you.
Yeah.
Yeah. I've got to, keep
Right,
it,
yeah,
keep
yeah.
it
I was like,
interesting and fun. Okay. So go ahead.
This looks regularly irregular. With a rate of 75, 80. If I'm counting correctly.
Yeah, you're good.
Okay, I was waiting for the no,
Good,
so.
good, great.
You're wrong. You're wrong. P waves are present and upright. Oh. That was one weird one. No, okay, yeah, never mind. Yeah, P waves are upright. This is just like normal sinus with like sinus block.
Yeah.
Okay.
Yeah, perfect.
Okay. This rhythm is irregular. About. I'm gonna recheck. 1 second. Let's do another method for the rate because it's a little bit sketchy. Oh, 40 BPM.
Okay.
P P waves are regular and inverted.
Okay.
PRI is 2 boxes, so short. QRS is normal. So I'm gonna say this is a normal junctional rhythm.
Yeah, except the way you say it is just, you can say junctional rhythm or junctional escape or even ectopic junctional, but not normal junctional.
Okay.
So,
Junctional is not normal.
yeah, or whatever. You know, I mean, it's, again, it's just names, so, yeah, but just junctional rhythm is perfect. Okay, Brandon.
The rhythm I think is irregular, the rate I think is around 170. I see P waves maybe with a normal PR.
I think those P waves, it's so fast, I believe those are T waves.
Well, I see a couple, so I think there's an upright one right there, one that's inverted right there, and then sometimes over here I don't see any. So I was thinking it was more of like MAT, but
Okay, so is it impossible for it to be MAT? No, it's not impossible. On the other hand, it's more likely to be atrial fib. And what you're seeing are not P waves, but just the normal junk that accompanies atrial fib, the isoelectric line.
okay.
But let me put some logic to it so you know how to deal with this. Is that multifocal atrial attack is pretty rare, and it tends to be associated with specific patients, as I described in the lecture.
Yeah.
For that reason, the only time you're going to have multifocal atrial attack on a test, unless I tell you it's multifocal atrial attack, would be like where it's 120, where you could, kind of like that one that you asked about before, where you can really see the P's. The problem here is based on the ECG, I really can't tell whether it's AFib or MAT, but AFib is so much more likely that you really need the patient, you know, the clinical history of the patient to be able to rule in MAT. So you will not have MAT on any of my tests or on any of these things unless I tell you that's what it is.
Okay, would you put it on a test if you have like a question that had background to it, where you're like, here's the scenario, here's the rhythm, what is it?
No, because, no, it more likely, I mean, I don't think, I have no idea, but it would be more likely for me to say something like what would be a typical patient that was, that you would expect to have MAT.
Okay.
I would sort of probably turn it around the
So
other
just
way.
like
Yeah, so just, I mean, I don't want you to forget about it or not know about it, but I also want to take it out of this setting because it's so much more likely to be AFib.
yeah.
And based on the ECG, am I 100% sure it's AFib? No, but I'm pretty sure.
Okay.
Yeah. Okay, 18.
It is regular, the rate is 70. The P waves are both inverted and regular. And the QRS is, and the PRIs are both normal. Wandering atrial pacemaker.
Yep. Wandering atrial pacemaker. Good job. Okay. Last, but definitely not least, number 19.
Sorry, one second. Alright, so this looks regular besides that sinus pause in the middle. The rate is about 70-ish. P waves are present up until that pause. So I would say sinus, normal sinus with one sinus pause.
Well, I'm okay with the sinus pause, but what's this?
It's a great question.
Yes, my specialty. So, what do we call, it's an oddball beat, and most of our oddball beats are premature beats. But there's that other class of beats that actually comes in late. Who remembers what they're called?
Escape.
Yes, escape beats, okay. So it's an escape beat because it comes in late. Now, what kind of beat is it? The same rules apply for premature beat. If you have a narrow, complex escape beat with no P wave, where does that originate?
That is another great question.
So when we think of anything that has no P waves, inverted P waves, or retrograde, where does it originate?
I'm unsure.
Somebody help them out.
AV node.
Yeah, so this is a junctional escape beat. It's junctional because there's no P wave, it's escape because it's late. Now, there's two ways to say it. Normal sinus with a junctional escape, you're done, you're fine, okay? However, Harrison is correct. There is a sinus pause that caused this ectopic focus to become irritable. Okay, so you could say normal sinus with a sinus pause and a junctional escape. I'm okay with that. But I don't require the pause or the block or whatever in there, just because the escape beat, it kind of implies that there's a pause. Okay?
So normal sinus with junctional escape.
Escape. Yep. Okay, questions? Okay, let's move on, and I think we can sort of barrel through and get done without being late here. Okay. AVNRT, AVRT, and SVT. So, what can I say? Yeah. Okay, the last two dysrhythmias, definitely everybody's fave, and they are two very different different mechanisms. One is AV nodal reentrant tachycardia, affectionately known as AVNRT, and AV reentrant tach, which is AVRT. Okay, we're going to go through what both of those are. And sometimes people call these atrial subjunctional, so I just tack them in at the end. So, AVNRT, and that's what we'll call it, AVNRT, has to do with the structure of the AV node. Okay? Frequently, there are two conduction paths down the AV node. Sometimes these are truly anatomical pathways, meaning that there's something in the center that is non-conductive that creates these two pathways, or it can even be functional, caused by ischemia or something like that. Typically, for whatever reason, one pathway conducts faster than the other. So this is kind of what it looks like. Here's our AV node. For whatever reason, we have this non-conducting, the person could just have been born with this little patch of non-conducting tissue in the middle. And that means that when the impulse comes, it splits into two parallel pathways. Okay. Now, if you remember when we talked about reentry pathways, we compared the situation to a river, compared the electrical flow to water flow, and said, what happens if you place a boulder in the middle of the river? And if that's all that happens, it's no big deal at all, because the river or the electrical current flows around the area it can't go through, comes together, and if you're downstream, you have no idea that there was this split. But also, you may recognize that when we said reentrant pathways have to have special conditions to allow them to exist, this is the first condition. We have to have two parallel pathways. Okay? So most of the time there's no problem. If somebody has this situation in their AV node, they don't know it, just normal sinus rhythm. You wouldn't pick it up on an ECG, you wouldn't pick it up clinically. It's meaningless. Unless the conditions are just right, we're not going to get more detailed than to say the conditions are just right, to set up a re-entry circuit that's going to go round and round and round the AV node. And like all re-entry circuits, there are certain things that are true about this particular kind of re-entry circuit. It's very rapid, can be as rapid as 200 times a minute. It doesn't have to be that rapid, but it can be. It's very regular. It goes around and around in a very regular manner. And like all re-entry circuits, it starts suddenly. It doesn't build up. It's on or it's off. Let's say its rate, its intrinsic rate of this particular re-entry circuit, let's say it's 160 times a minute. That means it'll go from whatever the underlying sinus rhythm to 160, just like that. And when it collapses, it stops just like that, okay? It goes round and round and round and round and round like that, and every time it hits the bundle of His, an impulse will come down and depolarize the ventricles, which are going to lead to a very regular, rapid, narrow complex tachycardia, okay, which should sound familiar, okay? Now, sometimes when this happens, it also goes backwards and depolarizes the atria at the same time. And what you will sometimes get with AV NRT, that's what this pattern is called, is little retrograde Ps, just like junctional, because the atria will be depolarized usually just after the ventricles. Okay, sometimes you can see it, sometimes not. It's nothing we're going to worry about. Okay, now here we have another, we're building our case for SVT. We already have two rhythms in the basket for SVT. One is atrial tach and the other is junctional tach. Now we have AVNRT that's going to look just like atrial tach and junctional tach if it gets fast enough, okay? So this rhythm, for example, could be AVNRT, because this is exactly what it looks like, but it could also be atrial tach, it could also be junctional tach, and as we're going to learn in a few minutes, it could also be the fourth rhythm, AVRT, okay? The way we describe this umbrella, this basket of rhythms, is they're very regular, okay? Remember that re-entry circuit's very regular, it's very rapid. Narrow QR is complex because it's still supraventricular, and there are no discernible P waves, okay? So we now have 3 out of 4 of our SVT rhythms. We have atrial tach, junctional tach, AVNRT, and all we have to finish it off is AVRT, AV re-entry tach. Now, who remembers WPW? Remember that from previous discussion? Yeah, Wolf, Parkinson, White, is that what you said? Yeah. Okay, so it's actually better, what I'm going to do is jump ahead 2 slides because it just works so much better from a picture. There are people who are born with an accessory, what's called an accessory pathway in the heart. Okay, here it's, the picture shows it like this. WPW is the most common underlying condition, you know, named presumably for Dr. White, Dr. Parkinson, and Dr. Wolf. And what it is, remember, in a normal healthy heart, there's only one conduction pathway from the atria to the ventricles, and that's the AV node. But people with WPW have a second one from the atria to the ventricles. And it can be problematic partly because whereas the AV node is this complicated little structure that has a pause and a slowdown and all those things, this is just a bit of conducting pathway. Now, most of the time, people with these accessory pathways, no problem, they're in a normal sinus rhythm, they wouldn't necessarily even know that they have this. But every so often, the conditions are just right for a re-entry pathway to establish itself. And this is what we describe as a macro re-entry, because it's, you know, throughout big parts of the heart. And typically what happens is the impulse will go down the AV node, go up the ventricles, and boom, it hits that accessory pathway all ready to be depolarized, and it comes back into the atria, and you can see the reentry pathway right there. This is the most rapid of all of the SVT reentry pathways. It can be as fast as 220, 240. It can be really fast, okay? So the impulse almost always goes down the AV node and back up the accessory pathway. We call that orthodromic conduction. You don't have to learn the term. I just sort of tossed it in because occasionally it'll go back the other way, and then we call it antidromic conduction. You don't need to know that term either. Okay, so now I'm going to go back a couple slides. So, most of the time a person with WPW is in normal sinus rhythm, has no problem, but AVRT occurs when a reentry circuit is created using those two pathways. Back to the picture. This slide, don't worry about it, it's just kind of a bookmark of things to come. I put this in so if somebody raises their hand and says, what about that delta wave? Well, I'm telling you, we will learn about delta waves, but not now. Spring term. We will learn about this and this, not now, okay? So, when the rate is so fast, AVRT is, again, one of the rhythms that comes under the umbrella term of SVT. We now have all four. We have AVRT, AVNRT, junctional tach, and atrial tach. Again, here we have it again. This could easily be AVRT. It's regular, narrow complex, very rapid. These are the T waves, so no discernible P waves. It could be AVRT, it could be AVNRT, it could be junctional tach, it could be atrial tach. Okay, so now we're going to pull it all together and talk about SVT and what it means for us. So, we use the umbrella term SVT because most of the time we can't tell these four rhythms apart. Okay, they look exactly the same. Discussion of SVT, and I love this because I made this slide quite a long time ago, and it's Halloween, so perfect. So, now, first of all, the term SVT has two different usages, okay? And I can't help that. I didn't write the rules here. You will hear SVT to describe two very different things. And you need to learn that because otherwise you're going to get mixed up. It's very confusing, okay? SVT is short for supraventricular, that's the SV, tachycardia, that's the T. What does that mean? What does the term supraventricular tachycardia mean? Brandon? Excuse me?
Above the ventricles.
Well, that's supraventricular and then tachycardia?
It's fast.
Yeah. So a supraventricular tachycardia, what it actually means, what the term means, is any tachycardia that originates above the ventricles. So let's explore that for a minute. So, Kay, give us one rhythm of any sort whatsoever that is tachycardic and originates above the ventricles.
Sinus tach.
Sinus tach, good. Haley, what's another?
Oh God,
You think of the SVT rhythms, you can steal any of those.
atrial.
Atrial tach, okay? Abigail? It could also be ones that could be tachycardic. There's a bunch of supraventricular rhythms that sometimes are slower and sometimes are faster.
AVRT. Yep.
Okay, AVRT, nice job. Okay, Harrison, what's another?
Oh, T for tachycardia.
AV nodal entry type.
Okay, Eli, what's another?
Would junctional tach be one?
Junctional tach would be another. Cami, what's actually, there's two that sometimes are slower but can get above 100 that are supraventricular.
Wait, what did he just say? Which one did he just say?
Junctional tach.
Junctional? Oh, yeah, no. She's helping me.
Yeah.
AFib?
AFib.
Okay.
Because it can go more than 100. So let's look at my list here. So these are all the rhythms that either by definition are tachycardic or like AFib and aflutter could be tachycardic that originate above the ventricles. So just hold on a sec. So here they all are. Now this is one use of the term supraventricular tachycardia. And the way you'll hear this is people will talk about the SVTs, the supraventricular tachycardias. And when it's discussed like that, you have to use the context. It's very annoying that we have these two different definitions for the same term, or the two different usages, I should say. It's not really a different definition. So sometimes when people talk about SVT, they're talking about the whole list. But if you walk on scene and the first responder medic says to you, the person is in SVT, they are not talking about sinus tach, they're not talking about AFib. Okay, they're talking about SVT, the umbrella term. So let's take that a little further.
Would Matt apply too?
Yes, it would. I just didn't put it there.
Okay.
However, when you walk on scene and somebody says, oh, the patient is an SVT, what they're referring to is something, shortening of the term PSVT, which means paroxysmal SVT. Now, paroxysmal sounds very fancy, but it's really simple. All it means is something that starts and stops suddenly. Re-entry circuits, okay? So remember, re-entry circuits are on or they're off. They don't build up like sinus tach does. They don't go faster, 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 faster. They're just boom, they're on. That's what paroxysmal means. And this group includes our four rhythm, atrial tach, junctional tach, AV-NRT, AVRT. So when we say SVT in this class, when I ask you what rhythm is that, and you say SVT, if it's sinus tach, don't tell me it's SVT, because you know it's sinus tach. When we say SVT, we mean it's one of these four because we can't tell them apart. So Harrison, you had a question right here.
Kind of answered it, but the last slide, those were all rhythms that fall into SVT.
Mm-hmm.
But PSVT are these four rhythms that
Yes.
are only, they're identifiable.
Well, they're not they're
They're not.
yeah, they're not
Okay, so-
identifiable.
okay.
Like we really cannot tell AV-NRT from AVRT from junctional tach from atrial
I
tach.
see, so,
Junctional tach, if it's slow enough, if we can see inverted P's,
okay,
then we're home free on that. But that's usually at about 120,
so
130.
these just fall under the umbrella of PSVT?
Yes, yes. Afaf, you had a question.
Why don't we just call them PSVTs then?
We're lazy. I mean, really, I don't know the answer on that. So, yeah. So again, the term paroxysmal means to start and stop suddenly. So remember, this slide came from when we were talking about re-entry tachycardia. So here is SVT. It's regular, it's fast, it's no discernible P waves, narrow complex, and boom, it just stops and goes right back into a sinus rhythm. Okay? Now, you're going to find this term to be common usage. If you walk into the emergency department and the physician says, what you got? And you say, oh, I have a patient in SVT. They're not going to say, okay, now do you mean AFib or sinus tach? They're going to know what you're talking about. Okay, that's how we use the term. Okay. Now, here's just a few additional facts. Atrial and junctional tach are both pretty rare. Okay, I've presented them as though they're all equal. They're not. The most common are AV-NRT and AVRT. So AV-NRT, that's the one round and round the AV node. That's the most common of the PSVTs, the SVTs that you see. About 60% will be AV-NRT. You won't know that, but it just is a fact. AVRT is the next most common. If the patient has a history of WPW, they tell you, or it's on their, in their medical history, and they're an SVT, the likelihood of it being AVRT is high. because you've got the underlying mechanism there.
Probably some of you guys already covered, but will we ever be expected to differentiate between the different types of SVT?
So clinically, how do we tell these four apart? Thank you. I plant an audience there. So no, you won't be expected to tell them apart, with exception, remember, I'm putting junctional tach in some brackets because if it gets slow enough, like at about 120, you can see the inverted P's. So I'm just putting that in a class by itself. That's junctional tach. Don't call that SVT because you can tell it. Okay, so the reason we can get away with this is we treat it all the same. Okay, now all four of these tachycardia, all four of these SVTs, with the occasional exception of atrial tach, which is pretty rare, they all have re-entry circuits that involve the AV node. Okay, junctional tach, AV-NRT, round and round the AV node, AV-RT, round and round the whole heart, but through the AV node. Now, remember what I said about re-entry circuits is they're fragile. And if you shake up the conditions that allow them to exist, and this is our strategy, if you will, with treatment, we want to shake up those conditions so we can cause those re-entry circuits to collapse, giving the sinus node a chance to come back. We're trying to break the re-entry circuits, if you will. So let's look at our various treatments. Adenosine, have you guys had adenosine yet before? What adenosine does is it stops the conduction through the AV node very briefly, for just a brief time. It just stops conduction. Well, that's a good way to shake up a re-entry circuit, is just to stop it for a minute. And it's a pretty effective drug, okay? It stops the AV node just for a brief moment, and that allows that, the goal is to collapse the re-entry circuit, allowing the sinus node to come back. Cardioversion typically is very effective with SVT, any of the SVTs, except again, possibly atrial tach. It's very effective because what it does is that it just stops everything in the heart for a moment, just for a moment. Well, that's a great way to shake up the, the conditions that allow the re-entry circuit to exist. So the goal is we stop everything that collapses the re-entry circuit, allowing the SA node to come back. And then calcium channel blockers, and typically, at least in this part of the country, medics will carry diltiazem, which is a calcium channel blocker. And what that does, it doesn't stop like adenosine, but it slows conduction through the AV node. So again, it's the same thing. We're shaking up those conditions that allow these re-entry circuits to exist. Now, for years and years and years and years, as far as pharmacological treatment, adenosine has been first line. With ACLS, it's right there at the top because it works very well. But does anybody either experience themselves or known anybody who has been given adenosine for SVT? Yeah, she like it?
Oh no, what I was just double checking my protocols because they didn't give her any benzo.
Well, you don't with adenosine.
With adenosine, you don't?
No, you don't.
That's messed up.
Yeah.
She did not like it. No.
No, she did not like
She
it,
did
right?
not like it,
What'd
no.
she say?
Well, it's literally like having your heart restarted.
Yeah,
Wow.
yeah. Now, for some people, it's not so bothersome. But the descriptions I've heard are things like, it felt like somebody hit me in the chest with a 2x4. You know,
Yeah.
for some people, it's very painful. I had a friend who actually was a paramedic who refused to go to the ED when she was in SVT, because a lot of times they'll fit the SVT will go away by itself. Because she just hated it so much. So as a result of that, but adenosine is very effective.
So you don't.
No, with cardioversion, well, see, we wouldn't even do it with cardioversion because benzos take so long.
Or it looks like a midazolam is recommended for
With adenosine?
cardioverting.
Oh, for cardioversion.
Oh, this is cardioverting.
Yeah, for
But
cardioverting. Yeah, but I'll tell you what, I mean, you can't, no, you could give midazolam for cardioversion, but the truth of the matter is,
What would be a reason not to give it for adenosine? I'm sorry, I interrupted.
Oh, because I don't know the answer to that. I really don't. Let me think about that.
Because when she was there, she was told the reason they didn't give her anything was because they thought she was driving home. Like, it didn't seem like there was an actual contraindication for.
Well, here's the deal. Let me go back to the
Sorry.
reason why, with cardioversion, you give midazolam, but midazolam takes a while for it to work. And so, if you have long enough to wait for the midazolam to work, you might just even transport in and probably would cardiovert if you felt that it was unstable.
Oh, so in the field, it makes more sense that we don't. But if they're in the ED, I feel like.
Oh, if they're in the ED,
She was
they
in the
always,
ED
they
when they
always
did
do, they always do unless the person was unstable, and I guess unless they were driving home.
Yeah, they just made an assumption, she was mad, well,
So
I
was
was
she
mad for her.
cardioverted or given the adenosine?
Adenosine. She was given adenosine in the ED.
Yeah, I'll check into that, because I've actually never heard of anybody giving midazolam with adenosine, but maybe.
I
that's
don't know if it
different.
was midazolam, but I just know that after it, because I picked her up because I was late in getting there because I just wasn't able to get there for the actual fun part. But since she had driven in on her own, they just kind of assumed she would need to drive home and didn't discuss that with her. But she was not happy that she
Yeah.
wasn't given something.
Well, anyway, so diltiazem is a much more gentle way to treat SVT, and it's becoming, for years adenosine just has been used simply because it's so effective. It does work. And so I think diltiazem or some other calcium channel blocker for SVT as first line might be on the horizon, and within, I'll just make up a number, 5 years, that might be what you're giving for SVT. Okay, I don't know that for sure, but I keep hearing little things about that. But anyway, that's why we can use the umbrella term. The treatment is the same. It doesn't matter that we can't tell AVNRT from AVRT. Yeah.
This might be going beyond the
That's
scope
okay.
of this class, but you mentioned briefly when you were talking about cardioversion before that it wouldn't be very helpful with maybe atrial tachycardia, and I'm wondering, like.
Oh, no, cardioversion probably would be. I'm sorry, I was thinking adenosine.
Oh,
So
great.
it's the only, if you think about atrial tach, it's not, it could be a reentry circuit, but it's up in the atria.
Okay.
And so if you stop, sometimes adenosine could help, but you're not actually interacting with the reentry circuit itself, because it's up above.
Okay. But
You're not gonna know.
We don't know. We would
You're not
still
gonna
give
know.
it, and it just wouldn't.
Yeah, it just wouldn't work.
And then we would
You're-
probably go on to a different.
Yeah, and
treatment.
you wouldn't, atrial tach is the hardest of all of them to convert, but you're not gonna know, and it also
And
tends to be
you
pretty
said
rare.
rare. So.
Yeah, so it's nothing to worry about. Okay, questions? Okay, so we're gonna stop there. Oh, except I'm gonna jump ahead for one thing at the very end, one slide. We'll do the last bit next week, but this part you need to know now. So this week, you really need now to have as part of your regular ECG homework is to be practicing. And I think some of you have, because you did pretty well today. But you can practice in the atrial and the junctional chapter. And, ideally, nobody's life is ideal, and you can't always organize ideally. But ideally, if you can do it every day or every other day for shorter amounts rather than one big mega practice like once a week or something. It's that kind of thing where you just keep doing it and keep doing it and keep doing it, and you'll start recognizing these things. So that just goes without saying. You need to be practicing in your Huff book. Now, there's one problem with that.
Wait, I just had a quick question about
Yep.
this is just about the answers in the Huff book, how they're always so precise with their heart rates.
Uh-huh.
Are we just supposed to get in a ballpark? Like
If
within
you're
5
getting
or
within 10.
within 10 of those,
You're good.
okay.
You're
How,
good.
is it
Within 10.
possible to get that?
Yeah, it is, because you know how we do the boxes method, there's a small boxes method.
Oh,
there's
so,
only 0.2
but we're just gonna
times
stick
whatever.
with our large boxes.
You
method?
know,
Yeah.
I think if you can get it within 10, that you need to do that. When we're in the field, you almost never do that because you're just looking at the models.
Okay.
Yeah. But you do need to, if you're getting within 10,
Yeah, okay,
that's
I
fine.
just wanted to make sure, cause I'd go
Yeah.
back and I was just like, how'd they
How
get
did
so
they get
specific?
87.5? Yeah. Okay, so there is a mistake in Huff, and it's persisted over all of the editions. It's now gone on long enough. It's out of date, so I can call it a mistake. When you see SVT, meaning narrow, irregular, no discernible P waves, and narrow, irregular, rapid, call it SVT. What Huff calls it all the time is paroxysmal atrial tach. It's the only SVT that she uses for SVT. And it makes no sense for multiple reasons. Number one, atrial tach is the most rare, so why call all of them? And the other thing is, it's out of date. Even the term, nowadays, even if you were to say atrial tach, it's usually ectopic atrial tach, you know. PAT is a really old term, so I don't know why it's in all the new editions. I know why it's in the old editions. So when you're practicing, you see something that looks like SVT, you go to the answers and say, I thought it was SVT and it's paroxysmal atrial tach. You are right, she is wrong. Okay? So it is SVT.